we're talking about early disease and the vagaries of early detection and prevention today. And then some of the therapeutic strategies are tomorrow, and then followed up by the quality of life outcomes towards the end of the day tomorrow. So and I encourage you very, very strongly, tomorrow actually, from a take-home message standpoint, much of today is some theoretical impacts as well as very important clinical messages, but I encourage you, I hope it's raining and storming tomorrow or something like that, so you won't go out and enjoy the San Antonio weather. You really need to be here tomorrow in the morning and the afternoon to hear some of the really fabulous presentations I guarantee you that you'll see. So what the next step is to discuss some of the things I hope I piqued your interest with during the first presentation with regards to prostate cancer prevention. And you can see pretty clearly why prevention might be of importance. There are some problems with early diagnosis. One is that it's costly, it's potentially morbid. We don't know our impact. As was said earlier, I think Tony pointed it out that there are lots of people who have opinions with regards to early detection, and certainly data don't help them form those very well. Unknown impact and certainly the possibility of overtreatment. We know mortality has diminished, as we pointed out earlier, to differing degrees in different ethnic groups. We know it's rising in other countries, but we don't know the impact. Great example of this, a paper that I think that Barry pointed out to me a number of years ago, was a paper in Lancet a couple of years ago in which they pointed out the change in the prostate cancer diagnosis in the US versus the UK, and the fact that in both countries mortality fell. So we really don't know that early detection makes a difference. And then we have the other problem. If you're wearing your public health hat, you can detect it early. You can wait until it causes metastatic disease when you know it is biologically significant. But the problem with metastatic disease is we had no difference in outcomes since 1950. Really no significant evidence that we've really affected the outcomes of metastatic disease. So our options, as I pointed out earlier, are innumerable. There was a WHO consensus conference in Paris earlier on this summer, and the document that came out of the prevention working group, I think, was almost 100 and some odd pages in length, with some 400 or 500 references, and we actually had to trim the references because there were so many issues that had to be addressed with regards to prevention. As I said earlier, the real target for prevention is the fact that you don't necessarily have to prevent prostate cancer. If you can delay it long enough, since the average impact on life's years lost is about 9, you can slow it down. So if we can intervene at any point along this process and truncate the natural progression of prostate cancer, we may be able to make a difference. This is a slide that Howard Parnes sent me from the Division of Cancer Prevention, and it's a fairly a good example of how prostate cancer may progress over time, where we have normal cells on the far left to initiated cells to varying degrees of precancerous change. And a good example of this is I had a phone call from one of the data coordinators for the prostate cancer prevention trial yesterday, who had an interesting problem. At the end of the prostate cancer prevention trial, I'll show you in a second, there's a biopsy of all participants on the end, and we have a central pathology core laboratory, and the central pathology core laboratory called it atypia, which is somewhere in between this process of in these 3 precancerous phases, as you see here. It was sent to a reference laboratory on the East Coast, and the East Coast laboratory called it prostatic intraepithelial neoplasia, okay, which is a little bit further along that process. It's a precancerous, we think, condition. And then it was sent to the local pathologist, who read it as benign. So the data coordinator was calling me up and said, what should I tell the patient? I got one person that says it's benign, one says it's partly precancerous, and the third one says it's precancerous. What do we do about it? The whole concept being is that there's probably a spectrum, and the human brain's ability to detect the patterns associated with each one of those very subtle nuances of histologic change are very challenging. And that prostate cancer, the one advantage is that the atypical change before you get this prostatic intraepithelial neoplasia, maybe 20 years, maybe another 10 years before you get invasive disease, and then 3, 15, 20, 30 years before clinical carcinoma. And so we have many opportunities to prevent the disease. Primary prevention would occur before clinically significant and localized disease develops, anywhere in between. And secondary prevention, early detection, intervention, and so forth could occur anywhere in those next steps. As I said earlier, lots of opportunities. Dietary fat is one of those. Really intriguing opportunity. I'm not convinced, being a clinical trialist, that this will ever work in the United States, unless you give everybody a free ticket to Luby's, which is, for those of you out of town, which is one of our local cafeterias, that you get the ticket, you go in and you get fed every evening. I'm not convinced that the US will actually do this. But there are any number of constituents in the diet. One of the more interesting ones, in terms of dietary impact with regards to prevention, got a lot of press. If you have people who are at risk of prostate cancer or people with prostate cancer, almost guarantee you at least half of them are taking this, lycopene. And this is, the data from this comes from Ed Giovannucci's Physician's Health Study, where they followed 47,000 and change individuals for a long period of time, and then did tremendous number of dietary assessments, and what bubbled up was lycopene as having about a 20% reduction in prostate cancer incidence in this group. Now, where this came from when they talked about food substances was tomato sauce, tomatoes and pizza, and you can actually go into a tremendous amount of detail about where lycopene comes from, and the fact that it's a carotenoid. It's what gives the red color to tomatoes. It gives the red color to watermelons and other substances, and it's kind of a variant of vitamin A, if you will. The challenge with it, and the other interesting things, is that you can actually go into detail about how you should do it. The lycopene is not absorbed well from tomatoes, so you need to cook it, and then it's not absorbed in a water environment, so you have to take it with a little bit of oil, and so the obvious best thing is to take some tomato sauce on a pizza with some cheese, or my approach to it is perhaps some tomato sauce, some cooked tomatoes, some mozzarella, and some balsamic vinegar and nice virgin olive oil over the top. But obviously that's a cooking show, so we're not going to go there. But the interesting thing about these observations with regards to prevention is to go back to the original article. And the original article looks at some 20 or 30 or 40 individual items that were a component of this. And lycopene was what bubbled up. Well, we know ourselves that there are risks when you do case control studies or epidemiologic studies of the such, that if you look for 20 different variables in a diet, you're almost assured, my statistician colleagues tell me, to find, if you use an alpha of 0.05, you'll find one that will bubble up. And from one of these similar studies in the past, we found, for those of you who are sufficiently old enough, that vasectomy, a history of vasectomy, was associated with increased risk of prostate cancer. And over a period of another 10 or 15 years afterwards, multiple case control studies, multiple longitudinal follow-up studies suggested it doesn't make a difference. So these are hypothesis-generating studies that suggest that this may have an impact. And there's actually a little bit of data in phase 2 trials. Omer Kuchik had one with lycopene that has looked at this one component of diet that suggests that it makes a difference. But at this point in time, our ability to tell a patient, go out, buy lycopene pills, which is what they tend to do, take it, prevent prostate cancer, we don't have the data. Some other interesting possibilities, isoflavonoids, and I think it's one of the most intriguing ones. And Carol Moinper's in the back. She knows John Potter, who's an associate of hers, who's a nutritionist at the Fred Hutchinson Cancer Center. Actually has very much of an interest in this, and he was relating the story to me. Isoflavonoids are weak plant estrogens that were first identified in clover disease in sheep, and it was some issues with regards to infertility in sheep in Australia that were eating this red clover. And John was originally from Australia, I believe, grew up there, and tells me the story of his goat. Not many of us have a goat, and his goat, when the clover would bloom, this red clover, the goat would go into milk and remain in milk until the clover died back out. And if you ever had a ruminant that you took care of, a horse or a cow or a goat or a sheep, you know that these animals will invariably go to the clover instead of the fescue. This is for a horsing person from the Midwest. So it illustrates the fact that these weak estrogens are indeed biologically active. And they're obtained from a variety of sources in the diet. And certainly one of the sources that constantly comes up is soy. because remember we talked about earlier the differences between North America, Northern Europe, and Asia, the dramatic differences, 20, 40-fold difference in risk of prostate cancer. One of the considerations is that it might be the fact that in the United States most of our protein comes from meat. In the Asian countries, much of the protein is plant-based protein. A lot of it comes from soy. There's a tremendous amount of these isoflavonoids in this, and it may explain some of the differences. Good example of this, I think this is Ross's study where he looked at excretion of phytoestrogens in the urine in Finnish men as opposed to Japanese men, and it doesn't, even a urologist can tell that there's a difference between those green bars and those blue bars, that there's a dramatic reduction. Interestingly, genistein, one of the most common one of those phytoestrogens, nothing in prostate cancer is superficial. Anybody who tells you that there's one right answer doesn't understand the nuances of the disease. Turns out that these phytoestrogens, their absorption is based upon your gut flora. So one person may take a certain amount of genistein in his diet and may have a tremendous biologic effect with a given gut flora, and another person has absolutely no impact whatsoever. So dramatic amount of intra-individual variation. These are some data from Barry Timms at the WHO conference that he was gracious enough to loan to me that demonstrates in a human prostate cancer cell line that variations in genistein concentration will vary the cell growth. And this has been demonstrated quite nicely in other animal models, other cell cultures. The one that I remember the most vividly was the beta-carotene studies in animals, the carotenoid exposure of one of the, I think it was the Lincap cell, where certain concentrations actually led to a more vigorous growth of the cell culture and other concentrations inhibited it, suggesting that there may be a biphasic response. So that's one of the potential targets, dietary speaking. Vitamin D is a very interesting one. The observations have been made many times over the past that physiologic levels of 125 vitamin D inhibit proliferation of prostate cancer cell lines. No controlled clinical trials in humans for prevention, but fascinating observations from the University of Washington and the University of Oregon, where Tamaz Beer is using calcitriol in combination with chemotherapy and having dramatic impacts on individuals with advanced hormone refractory prostate cancer. But one of the really interesting observations epidemiologically was this is a linear surface map, county by county of the United States, of your risk of developing prostate cancer, with the Maine folks having the highest risk and the folks down in Texas, Arizona, New Mexico, and so forth having the low risk. And if you superimpose this on this UV exposure, it's basically superimposable. And Ed Giovannucci's trial, the one that I told you about, the lycopene, had several other correlates within that, not the same paper, that demonstrated very similar observations, that if you increase the calcium in your diet, turning off vitamin D, there was a higher risk of prostate cancer. So an interesting observation that could be taken forward into a prevention opportunity. But certainly the one that was really the most interesting, and it's the first time I met Otis Brawley in the basement of the Executive Plaza building in Washington, 1991, I believe, in the summer. Dr. Brawley was with the Division of Cancer Prevention and Control at the time, and met him after Dr. Coltman and I were invited up to discuss the Southwest Oncology Group's role with the possibility of a prevention trial for prostate cancer. And the Board of Scientific Counselors of the Division of Cancer Prevention and Control, as it was called, it's now DCP, came to the conclusion that there were some opportunities that were watershed at that point in time. And it really comes down to the hormonal hypothesis of prostate cancer. Several observations. Number one, the two things that is really germane to this conference, the two things that are required to develop prostate cancer is three. You got to be a male, generally. Two, you got to get old. And three, you have to have androgens, because individuals who are born without androgens in utero, and actually individuals whose androgens are deprived in the prepubertal, there are two times the prostate is imprinted with androgens. One is in utero, and one is at puberty. And at puberty, testosterone goes up and tremendous virilization and so forth. Those two events seem to be critical for the development of both BPH and prostate cancer. So we know that androgens are required for prostate cancer at least early. If you make it doesn't make a difference after puberty in terms of risk. And populations with lower 5-alpha reductase levels, 5-alpha reductase is the enzyme that takes you from testosterone to dihydrotestosterone. And dihydrotestosterone is the one that's active in the prostate predominantly. It has the greatest affinity for the androgen receptor. Populations with lower levels, we all have different variations of our genes, and they affect the enzymes themselves. But those populations with lowest levels have the lowest risk. For example, Japanese seem to have lower 5-alpha reductase activity, lower DHT levels. We know that if you deprive someone with prostate cancer of hormones, or somebody without prostate cancer of hormones, normal prostate cells and prostatic cancer cells commit suicide. They go into an apoptotic process. We know these observations with regards to diet might be hormonal. So the Asian risk may not be genetic, it may not be latitude, longitude, and whatever. It may be having to do with the fact that they're taking a higher level of estrogens in their diet, may reduce their risk. Animal models, most animal models of prostate cancer require very high levels of testosterone to induce the cancer to develop. And many of these animal models suggest that 5-alpha reductase blockade can make a difference. Here's some of these, just some observations on these evidence. This is 5-alpha reductase activity in different ethnic groups. This is Ron Ross's data from Japan. You can see the Japanese, if we call the index level as Japanese, the US whites and US African Americans have higher 5-alpha reductase levels, thus higher DHT levels, one would expect. Not a lot of good studies in animal models. And I'll be the first to tell you this study is not very good, but it does make an interesting observation. And the problem with it, you'd like to be able to think that you could do a prevention trial in an animal model. Well, most animal models don't function like prostate cancer in humans. Most of them don't make PSA. Those that make PSA don't behave like prostate cancer. Most don't go to bone. Most don't develop blastic metastases. So it's very challenging. And most of them you got to give really high level of testosterone to. This is a F344 model where you have to put in an implant, very high levels of testosterone to induce the cancer. But in this study, in addition to a carcinogen, DMAB, the administration of finasteride to the animals reduced the risk of prostate cancer, both visible and microscopic disease, as you see here. So we had in 1991 this series of events. First off, this growing evidence that androgens were related to prostate cancer risk. Two was the discovery of 5-alpha reductase. When I started my training, we really didn't know very well, didn't understand very well why the prostate developed in some people and why there were these intersex states in which children were born, looked phenotypically like girls, except a little bit of clitoromegaly, and then they hit puberty and they virilized. And there were groups in Dominican Republic and Turkey and Great Britain and in Borneo, a bunch of regions around the country where these kids were studied, and Imperato McGinley and some other folks went to Dominican Republic, studied them, and found out what actually was happening was they had 5-alpha reductase, the gene and the enzyme, the SRD5A2 gene that codes for that enzyme, but there was a single nucleotide polymorphism that changed the gene, changed the protein product, and so they had the enzyme that takes testosterone to dihydrotestosterone, but it didn't work very well. And what happens was, in utero, low levels of testosterone didn't virilize their internal genitalia. Hit puberty, testosterone goes sky high. Those of you who have boy children, you know that that's the case, goes sky high at puberty. And what it does is that enzyme was able to translate to DHT and they virilize. In these kids with this genetic defect, they don't develop prostate cancer and they don't develop BPH, they have a rudimentary prostate, suggesting that the error of nature reduces the risk of prostate cancer. So that discovery occurred. And then what happens? PSA is discovered. And we have this huge bump in detection of prostate cancer, and there's this forecast that every single person over the age of 40 will ultimately be diagnosed with prostate cancer. Huge public health concern. And then a drug is developed that is targeted specifically for the 5-alpha reductase enzyme for BPH. It's finasteride. It's the first drug that targets this enzyme. It competitively inhibits it, so it takes that testosterone, blocks the testosterone translation to dihydrotestosterone, so it maintains testosterone levels. Actually, they go up a little bit, so libido's unchanged and so forth. Previously, any hormonal intervention would be unacceptable to men for the prevention of prostate cancer because it would affect libido, sexual performance, and so forth. No good. And so we get to this watershed event, and Paul Lang actually wrote an article, an editorial in New England Journal with the description of finasteride, said, my goodness, is the prostate pill finally here? Is every single guy over the age of 35 or 40 going to start taking finasteride? And the Division of Cancer Prevention and Control said, we need to study this while we have the opportunity. Let's see if we can prevent prostate cancer. And here's this is effectively what happens to testosterone goes into the cell. At the level of the nucleus, it's acted upon by 5-alpha reductase to cause the formation of DHT. Both testosterone and DHT affect the androgen receptor to cause an increased number of processes within the cell growth, cell cycling, protein production, and so forth. But DHT is the primary androgen in the prostate. So with the concept that we should, in clinical trials and in clinical medicine, the moment you have a good idea is the time to start the study, especially in prostate cancer, whereas if you wait a long period of time, you may lose the opportunity. In prostate cancer, it takes such a long time to answer your questions. And so the prostate cancer prevention trial was designed in 1991. Bunch of challenges. What's the endpoint going to be? Are we going to give half the people finasteride, half the people placebo, and then follow them for survival? The statistician said that's not a good idea because you need about 300,000 people, and you'll never publish it in your lifetime. And then by then, no one will care anymore. The second thing is that finasteride is a real bit of a challenge in a clinical trial because it lowers PSA. And the principal way prostate cancer is detected in the United States is by virtue of PSA. So that's a bit of a problem. And then we have the sample size issue. It's going to be a huge trial. And the other issue is finasteride. You look at the label, it says can cause erectile dysfunction, decreased libido, decreased volume of ejaculate. Would a healthy guy be willing to go on a trial where he doesn't know whether he gets placebo or finasteride, and if he gets placebo, there's no impact practically. If he gets finasteride, can cause sexual dysfunction for a disease process, people say it'll never occur. Well, the trial was designed to look for 18,000 healthy men with a normal rectal examination and a low PSA, placebo run-in, and then they were randomized to finasteride or placebo. And then down at the bottom, as you see, they have annual rectal exams and PSA determinations. The PSAs are actually adjusted so that there's an equal likelihood of a diagnostic biopsy in the two groups. And at the end of the trial, perhaps the most important thing that was actually it's wonderful that finasteride causes the problems with PSA because it forced us to do something called an end-of-study prostate biopsy, which will give us much more information, I think, than almost anything else in the trial, with the question of whether finasteride reduces the risk of prostate cancer. Those are the sites. There are 222 sites in 40 states. And well, we answered the first question, that guys are interested in prostate cancer prevention. In fact, when the day after the press conference at the NCI, the Cancer Information Service phone line received its greatest volume of phone calls it ever received before that, only surpassed by the next day. And many of these sites reached their enrollment numbers within a month or two and just shut the doors and said, we can't take any more folks. And the trial actually over-accrued. It was a 3-year accrual period. It actually over-accrued with almost 19,000 individuals accrued. This is where they came from around the United States. A lot of people from everywhere, including a large number in San Antonio. San Antonio actually constitutes, I think, about 11% of the total trial registration. And you see there are a few dots north of the border. There are, I think it's there's a site on the other side of the border from Michigan, and I'll think of it as Thunder Bay. Thunder Bay is the place where they came from. So results, and the question was asked earlier, are the results? None. Some observations, because the trial is not completed yet, and the trial, the proper way to do a clinical trial like this is to let it all get done, determine truly that you've reached the conclusion of the trial, and then report them. So there are no initial early results. But the age of the patients, participants, because they're actually not patients, there's nothing wrong with them, they're healthy guys. As you see here, about a third of the people are between 55 and 59, a third are 60 to 64, and about a third are over 65. Their PSA values, fortunate, we're delighted that about half the individuals' PSAs are less than 1. That's a good thing because a normal rectal exam and a PSA less than 1 indicates you have a very low likelihood of baseline having prostate cancer. We did not have a biopsy at the beginning of the trial because we were concerned that that would inhibit individuals from going on the study. 15% of the individuals had a family history of prostate cancer in a first-degree male relative. It's a huge undertaking for those of you who are interested in the concept of prevention, especially, you think prevention for prostate cancer. Why do you need 18,000 people for a disease, the most common cancer in men? Well, you do. It's your lifetime risk of developing prostate cancer in the U.S. is about 16%, 15-16%. Lifetime risk of dying from it's 3 or 4%. But it's a huge undertaking, and as of September of 2000, there were 4 million pages of data. The really challenging thing, all of these things are op-scanned into a computer, and the really disappointing thing was when I went up there to look at the computer, it's still no bigger than my one in my office. Isn't that disappointing? Michael Dell has done wonderful things. And the statistical center, as I said, is located in Washington, the operations office here in San Antonio. But there are things have changed. And anytime you do large-scale clinical trials in any disease that's kind of chronic and long-term, is that you may think that you're trying to answer one thing at the beginning, and you find out at the end that you're maybe answering something else. And in the interim, and some of the folks who are participating in this process here, we are beginning to understand some of the differences in androgen metabolism. First off is if you look, that's the cascade, and you don't need to remember any of these things, but you can tell some of these things are in yellow, and those are the genes that code for those enzymes that take the upstream precursors of testosterone and DHT down to testosterone and DHT. And remember, the testosterone, which is the T, and the DHT, the dihydrotestosterone, interact with the androgen receptor and cause the effect at the level of the prostate cell. Each one of those genes has a variety of polymorphisms. Single nucleotide, sometimes a little bit different, and the androgen receptor has some differences as well. That SRD5A2 is a specific gene that codes for the type 2 5-alpha reductase that's found in the prostate. And now we know that there are variations in that gene. So it makes it a little more complicated. We thought that we were competitively inhibiting type 2 5-alpha reductase. Well, it turns out that there are variations in that enzyme, the gene that codes for that. And you look at the efficacy of the enzyme on the left-hand side, that's a log scale. So there's about a 200-fold, 100 to 200-fold variation depending upon your individual polymorphism of your gene. The thing that makes it even more challenging is the one on the right is the impact of finasteride on the enzyme based upon the genetic variation, because finasteride, what it does is it interacts with the enzyme and it competitively inhibits it. And if you have a single nucleotide change in the gene for it, that enzyme folds a little differently, and finanasteride's ability to implant and to cut off the enzyme, if you will, is altered. So it turns out there's about there's a large difference in an individual. One of you in here might take finasteride and have a huge impact, for example, on BPH symptoms, and another individual may take it, have absolutely nothing at all. So the confusing thing is, how does this work with regards to the PCPT? Well, I'm going to give you a hypothetical outcome. This is strictly hypothetical, has nothing to do with anything, but just to show you where we may be going in this study and in future prevention trials, that say, for example, there's no difference, finasteride or placebo, with regards to the impact of finasteride on prostate cancer diagnosis, 6.2%. But then let's say, what happens if we genotyped the individuals who enrolled in the trial looking for the SNP, the single nucleotide polymorphism, that makes a difference? And it might turn out that if you have that polymorphism that finasteride affects more greatly, you may have a 4-fold reduction in your risk of prostate cancer. So it makes the conduct of clinical trials down the road a lot different. So we may be using more targeted approach to prevention clinical trials where we know better mechanistically how the agent may work, rather than large-scale clinical trials in which anybody and everybody enrolls. Our current challenge with regards to clinical trials in prostate cancer is SELECT, and that's the selenium and vitamin E chemoprevention or cancer prevention trial. We know that the burden is substantial with regards to prostate cancer, and there's a lot of data, background data, that suggests that selenium and vitamin E may play a role. With regards to selenium, trial conducted out of Arizona, a number of sites around the United States, took individuals at risk of skin cancer and randomized them to selenium or placebo. Selenium is an essential cofactor of an antioxidant in the body. It's the second most important antioxidant behind vitamin E. And there's a lot of data that suggests if you live in a region of the world with low selenium in the soil, in which your diet is low in selenium, you're at higher risk of cancer. In a lot of epidemiologic case control trials that suggest if you have a larger amount of selenium in your diet, you have a lower risk of cancer. So Larry Clark did this trial looking to see whether or not you could reduce skin cancer rates by selenium supplementation. And lo and behold, just as it seems every one of these trials shows, no impact on skin cancer, but a serendipitous observation that there was a 2/3 reduction, as you see on the right, in the risk of prostate cancer in those who had selenium supplementation. Another interesting observation, the group at the NCI conducted the alpha-tocopherol beta-carotene trial in Finland. 29,000 and change Finnish smokers, very high risk of lung cancer. A lot of evidence, epidemiologic, that beta-carotene and vitamin E reduces your risk of cancer, specifically lung cancer. So they were randomized into 4 groups. You had a 50-50 chance of getting vitamin E or placebo or beta-carotene or placebo. Everybody got 2 pills. And the primary endpoint was looking for lung cancer. Turns out in alpha-tocopherol, no impact on lung cancer. Beta-carotene, now demonstrated in other trials, increased your risk of lung cancer. So your patients who say, "Doc, I'm taking all these things, at least they can't hurt me," patently untrue. Patently untrue. It makes difficult to make recommendations of take-home messages based on epidemiologic data. But their secondary endpoint was prostate cancer. They looked at the risk, 30-some-odd% reduction risk of incidence and 41% reduction in mortality, but the study was not designed to answer that question. Okay? So here's the results, as you see here, 151 prostate cancers in the no vitamin E, 99 in the vitamin E group. And it seems that the cumulative prostate cancer incidence increased. The difference seemed to be increasing over time. The really interesting thing is how do we explain the difference where those curves begin to diverge after 1 year of administration? Highly suspicious based on the biology of the disease. But the reduction in prostate cancer mortality, as you see there at the bottom right, was 41%. So SELECT was designed to address that question, and it's a classic 2x2 factorial design where a quarter of the people get placebo, a quarter get selenium alone, a quarter get vitamin E alone, and a quarter get both to see whether there's an additive effect. And if you believe the antioxidant hypothesis, which is probably naive. That's probably not how it works, but that's one of the hypotheses. If you believe, then there could be an additive effect, and you can actually tease out the differences. Selenium is using 200 micrograms, vitamin E, 400 milligrams. Interestingly, most people don't realize that ATBC trial, and most of you in the audience who are taking vitamin E, you're probably taking 400 plus milligrams. The ATBC trial was 50 milligrams. So the data that take us forward was 50 milligrams, but most people take 400, and vitamin E is a pretty safe drug as long as you're not hypertensive. Duration is minimum of 7 years, maximum of 12 years. And in terms of accrual, we're coming back to the same observation. Guys, older guys, are interested in prevention of disease. We anticipated it would take 5 years to accrue the 32,000 men. You can see here, as of April of this year, there were almost 11,000 men in the study. The study opened in July beforehand. So now, whether it's going to accrue at that rate, continue, and close within 3 years, hard to say. My best guess is some of these centers will be saturated, and it will probably take 4 or 5 years to finish the trial. One of the challenges in prevention trials is specifically this. Even though a tremendous effort goes out to recruit ethnic minorities and the underserved in prevention trials, as Dr. Brawley has published before, in therapeutic clinical trials, you see the same distribution of ethnic groups around the United States. Same distribution. But for prevention trials, it's very challenging to get healthy members of ethnic minorities involved in these trials. And you can see here that we would like to have larger numbers, but it still remains very challenging. And finally, I noticed that Joe Bosler is going to use the same slide. You see this older gentleman showing up to the pearly gates to see St. Pete, who says, "I'd have been here earlier if it hadn't been that they prevented my prostate cancer." So we kind of hope that this is the way we're going. but I think it's a naive approach, because currently we screen all men, we offer prevention to all, yet only 14% of men will be diagnosed, 3 to 4% will die of the disease. I think, kind of like our paradigm that we saw earlier, I think where we're really trying to go is an intelligent approach. Do we want to put finasteride in the water supply or in toothpaste, Men's Health toothpaste? I don't think so. I think the way we're going to go is a mechanistic approach to prevention, so that we take 100 characteristic US men, apply some kind of test to risk adjust them to see who's going to develop prostate cancer, and then identify those guys for whom treatment's going to be necessary, because there are probably men that we cannot prevent the disease, at least with what we currently have. Identify some men who may be prevented with other mechanisms, perhaps a change in their diet, and a final group of men for whom a mechanistic intervention that we can identify the cause in their individual person will prevent their risk of developing prostate cancer. I think we're going in that direction. The challenge is that it's a Herculean effort, if you can imagine the amount of variations that are all involved in these kind of prevention trials. And I hope that sufficiently muddies the waters. Thank you very much. So I think we have time for a couple of questions, maybe. Any, Jeff?
What's the structure of lycopene? Do you know if it's a monoterapene or not?
I thought a monoterapene was a fish. That's a joke. I don't know. Lycopene, if you actually look at it, it looks like a carotenoid. It has one of those things, has a ring on the end. It's a long chain, it looks like a carotenoid.
And it's in the peels of the tomato and the peels of the oranges?
I don't think it's in the peel. I think it's in the meat. It's the red color. It's the thing that provides the... I'm not an expert. Anybody?
It's in the meat.
It's in the meat. Good. That's way over my knowledge base. Yes, sir.
With respect to the finasteride effect on the prostate, did the alopecia people jump on that information as well with respect to alopecia?
With regards to balding, actually, interestingly, I get a lot of ADRs, adverse drug, things that come in, and a lot of the things have nothing to do with finasteride. If you take, it's the Indy 500 effect. I went to visit a friend of mine at the Indy 500 who runs the medical services there, and he showed me his hospital inside the track. And I said, "Wow, you're really able to take care of all of these people who have crashes." He says, "Well, we don't take care of them here. They're going to the trauma center." Well, what's this hospital for? He says, "Well, we have 500,000 people in the stands, and during Indy 500, we get a lot of all sorts of stuff." Well, the corollary to that is 18,882 people followed over 7 years. You get all sorts of stuff. And we actually forecasted that men 62 years of age followed for 7 years. If you just look at vital statistics, 20% will be dead 7 years later. That's an interesting observation. But the corollary to that is that in all those ADRs, I've never had a single person submit an ADR that his chief complaint was his hair grew back. So, no, not seen that. Yes, sir.
I thought the information about the 5-alpha reductase polymorphism is very interesting. You probably mentioned, but is the study as large as it is powered to detect that?
That's a fascinating observation. No. It's not. No, think about it. Because we really don't know at this point in time. If you look at the SRD5A2, there's a little bit of data that suggests that some of the polymorphisms increase your relative risk maybe 2 or 3-fold. So then if you increase, say, 2 or 3-fold your hazard rate of prostate cancer, this is a very poor statistical analysis. Some of these are very uncommon polymorphisms. So an uncommon polymorphism, increase your hazard rate by 2 or 3-fold, you still might need 9,000 people with that polymorphism to test it. Makes your brain hurt when you think about how you're going to design these trials. So it's really challenging for prevention. How do you develop the analysis for the target that you're looking for without knowing the results of the trial in the beginning? I mean, which one of these polymorphisms? So what will probably occur, I think, in the prevention trials is these large-scale trials will lead to hypotheses that will then lead to the definitive, or there are no definitive trials, but a better trial with regards to the outcome.
Maybe the study will give a better idea of what the frequency of those polymorphism.
Yes, and we're actually designing some translational investigations afterwards looking specifically at that. But the science of prevention is continuously maturing, but you're right. Subset analyses, any subset analysis of these kind of trials are not powered for that subset. I mean, for example, African Americans, not powered for that. It's powered for the final endpoint based upon all comers. Challenging, huh? Very good questions. Yes, ma'am.
On the report that came out in Lancet summer of 2001 on the beneficial effect of fish oil on a large set of people in the northern European country, I believe Norway. So what is the status with regard to prostate cancer?
With regards to prostate cancer, I don't know. It's there. I think if you did a Medline search of epidemiology or the term case control and prostate cancer, you'll get maybe 1,000 hits, Medline, and about half of them will say one thing for an individual subject and about half for another. There are, I mean, even dietary fat. There are inconsistent observations across case control trials. Fish oil is another example. Fish oil, the effect of fish oil, I mean, there's a whole bunch of different hypotheses.